Good morning. Thank you very much for the invitation. I've been asked to present or to respond to the question whether or not it's easy to distinguish urgency from another clinical presentation on patients with neurodegenerative disorders, and also how can we avoid over-medication. These are my disclosures. So neurodegenerative disorders include a number of diseases like Alzheimer's, Parkinson, prion, Huntington disease, spinocerebellar ataxia, spinal muscular atrophy, also the atypical Parkinson's and multiple system atrophy. The problem with neurodegenerative diseases is that due to the increase of aged population, this kind of disorders are going to be very common in the next future. They are common now, but in the next future is going to be worse. And it's expected for year 2040 to have 80 million people with this kind of disorder. The problem also is that the cost of taking care of these patients is very high. There's a clear need of medical care and hospital visit, and of course there is a clear impact on quality of life. The bladder dysfunction in this patient can be an integrated part of the syndrome, can be also due to other conditions, or can be a consequence of the treatment given. Obviously, comorbidities increase the rate of complication. Also, cognitive dysfunction and dementia clearly affect the lower urinary tract function. And also the problem is that most of the time, lower urinary tract dysfunction is not related to neurological disorder. It's rather related to lower urinary tract problems like BPH in men. Also, there are a number of phenotypes that share the burden of the disease, and it's important to identify symptoms and complications leading to further loss of mobility and poorer quality of life. Mixed pathology is common. Psychological factor and cognitive deficit interfere with coping, and lower urinary tract symptoms obviously have a major impact on state independence. In fact, quite often incontinence is the factor that determines institutionalization of this patient. From the pathophysiological point of view, the clear issue is the loss of the dopaminergic loss. The dopamine is very much involved in several functions, and the loss of dopamine makes produce some kind of alteration that quite often lead the patient to have the torso overactivity, and that's the reason why many patients with Parkinson's disease do have the torso overactivity. And the prevalence of lower urinary tract symptoms is very high according to the literature. Could be 30% at the onset, but it's increased over the time, reaching up to 70% after 5 years. Most common symptoms are the storage symptoms, but also it's possible to have avoiding symptoms. So as you can see in this slide, nocturia might be up to 70%, frequency is lower, but up to 46%, urgency 46%, incomplete entire and intermittent is lower, the prevalence is lower, but also assist. Also the problem is that the symptoms increase over the time. After 4 to 6 years, most of patients do have storage symptoms and also could have voiding symptoms, although it seems to be at a lower rate. Another issue is that the lower urinary tract symptoms are commonly the first symptom of a presentation of multiple system atrophy. So we have to be aware of this to be able to identify the disease as in any neurogenic disease. Sometimes incontinence is the onset symptom of multiple sclerosis, and we should be aware of this. In regards to urgency, Urgency is defined by the ICS as a sudden desire of avoid, difficult to postpone. And urgency produce the frequency, reduce voiding interval, and is the key symptom in patients with overactive bladder, and obviously in patients with neurogenic overactive bladder, as is the case of patients with Parkinson's disease and with neurodegenerative disease. What causes urgency is not well known, but we suppose that could be caused by central mechanism, like it's in the case of this patient profile, but also could be due to lowering tract mechanism like BPH, obstruction, or neural problem of the lower tract, or even at the urothelium level, which is very much on fashion right nowadays, because most of the research is focused on the urothelium, because we know nowadays that the urothelium has a metabolic activity which is even 5 times that of the detrusor. Is not only a barrier to prevent the pass of compound of urine to the blood, and also could be due to viscerocutaneous pelvic floor causes, like could be prolapse. But urgency is in patients with the detrusor overactivity or overactive bladder is different from that urgency in patients with bladder pain syndrome. Patients with other pain syndrome feel and refer urgency as fair to pain, while patients with overactive bladder or neurogenic overactive bladder complain of urgency because fair to incontinence. So this is the otherwise it's a mix of symptoms in between patients with pure overactive bladder and also patients with bladder pain syndrome, and sometimes patients with overactive bladder also refer some pain. But clearly the only symptom or the only way to distinguish from the clinical point of view is the fair to pain or fair to incontinence. Obviously, urodynamics is the best way to make a proper diagnosis. So urodynamics in patients with Parkinson's disease versus patients with BPH is quite easy to find out or to understand, because with urodynamics we can realize whether or not the patient is obstructed. But patients with Parkinson's disease, who also are, in patients with Parkinson's disease, it's very difficult to identify obstruction, because the reason that my colleague showed earlier, that patients do have the very high pressure, and we are not sure whether the voiding is due to the detrusor overactivity or is because of the detrusor because of low volume and low flow, or the patient is clear or obstructed. And this is why urologists, we always are concerned of relieving obstruction in patients with Parkinson's disease, because incontinence might be worse. Also, it's possible to have an idea in order to distinguish from the dynamic point of view, Parkinson's disease patient from patient with multiple systemic atrophy. We know that most of the time, patients with Parkinson's disease never develop the detrusor sphincter dyssynergia, which could be the case in some other neurogenic disease. But patients with multiple systemic atrophy are more likely to develop impaired contractility, which is not so common in patients with Parkinson's disease. But from my point of view, the most difficult situation in my experience is to identify obstruction in patients with Parkinson's disease at the time of making the decision of providing treatment to relieve obstruction. In regard to pharmacotherapy, from our point of view, the most common drug we recommend for patients with urgency incontinence is antimuscarinic drug. Now we have a beta-3 agonist, but there's not much experience in patients with neurogenic disorder. The problem with antimuscarinics, and we know that antimuscarinic drugs clearly affect cognitive function. Although the studies that have been performed are not, let's say, of high quality, because the tests to evaluate cognition are mostly performed with this mental scale, and it's not very reliable. But there is a clear indices that the patient with under antimuscarinic treatment might develop cognitive disorder. And also that the patient with all this story come from years ago, because it was shown in autopsy from patient with Parkinson's disease that they had cognitive dysfunction and under treatment with antimuscarinic, and they also had amyloid plaques in the brain, and has been clearly shown. And this is why all guidelines nowadays recommend to be very careful at the time of prescribing antimuscarinic drug in patient, in elderly patient, and particularly in patients with neurodegenerative disorder, particularly because most of these patients already have under treatment with a number of drugs who have antimuscarinic properties, and then the load of antimuscarinic is increasing with what with the drug that we prescribe. So the American Geriatric Society recommend, in order to avoid over-medication, recommend to us before taking OTC, over-the-counter drugs. You know, in some countries it's possible to obtain OTC drugs without a medical prescription, and so many people has the things that they are not dangerous, but it could be because they also have antimuscarinic properties. So we should provide them or ask them to make a list of and keep it updated, to review medication, to ask questions on why, how, and when, organize the medication, follow direction, report problems, and also clearly let them know drugs that they shouldn't take. So managing incontinence or lowering tract dysfunction in patients with neurodegenerative disorder is not easy. And obviously, it was already previously mentioned, oftenly the first measure is the use of PAD, and quite oftenly the last measure is also the use of PAD. But I would like to call your attention to avoid over-medication, and particularly to be very careful at the time of prescribing antimuscarinic drug. Thank you.
Thank you very much. Thank you very much. You have any question? Because we are in time, and we do have 15 minutes at the time of this workshop that we will sacrifice the impulse of continue with the talent, because we know everything has a full agenda for the ICS. You have any question? Okay, so it's me again. So.